Is it working? It's working. Hey, fantastic. We have got the lives working. That's good. Let's get Jazz on. Hope everyone's doing good in the sun. You don't all suffer from hay fever half as bad as I do. This week has been a nightmare. Hassan first on. Hey,
yo.
We're back. We made it.
You made it, man. Your live's working again.
Feels so good. I'm back on the top screen.
So happy before.
I'm back on the top screen. It's good. How you doing, buddy?
Excellent. I'm good. Oh, man, I'll tell you all about it, but what a crazy day I had. And my wife had to go for a COVID test yesterday. And because of that, all of a sudden, I had to rearrange patients and be like, okay, let's see what happens if we get the results back by midday or not. So I've been there in anticipation, came back 2 minutes past midday, just as we were about to cancel my afternoon patients, but came back negative. I went to work, but I usually work in the morning. So it's been absolutely manic, man. How about you?
I had a consulty day. It was 5-6 new patients, a few checkups, not a denture, well, a denture review, actually, I lied. There was a denture in sight, so that was good. Yeah, it was.
Did you get to check the retention and resistance? How was it?
Yeah, immediate denture fit, bit of suction, so that'll be coming soon, hopefully.
Amazing. Can't wait. Your photography, your photography, I always say this, man, your photography is beautiful. That you're on that Dental Leaders recently. You know, you make I think I'm the one who gave you that credit. You make something unsexy sexy, and they ran with it, which is cool.
They ran with it. Yeah, you got there first, though. You got your hands on it first.
Excellent. We're just saying hello to everyone. Hi, guys.
That's good. People know where to find us this time.
That's it. Let's go with Vertis, man. What we got from here? Should we just crack on?
I think first up is, what even is a Verti prep? I've just about got my head around tabletop onlays, and now Instagram's throwing another kind of indirect restoration at me. So come on.
Fine. Let's tackle that. Fine. What is a Verti? Let's tackle this now. Can you hear me okay? I'm just checking. Can you hear me all right? Okay, super. Right. Firstly, before I even talk anymore, I just wanted to, again, can you read that? It looks back to front to me, but can you read that all right?
It's back to front.
Yes. Okay, fine. Okay. This is Pasquale Venuti. Okay, that's Jason Smithson. This is Ignacio Loy. This is Alina Rizanova. These are all fantastic dentists. Italian, England, I think Italian, Estonian, right? These are people who've influenced me in terms of vertical preparation. I've been doing it for about 5 years now. And at first, like everyone, I was like, what the hell is this, right? So there's different names. There's vertical, edgeless, shoulderless, Etruscan. There's so many different names. But I just wanted to pay homage to some people who've sort of influenced me and helped me in a nutshell, right? In a nutshell. Do you like that?
Yeah, very smooth transitions.
In a nutshell, who needs PowerPoint? Exactly. In a nutshell, right? Sometimes to understand what something is, let's understand what it isn't, right? And I want to give it the best example I can give in how I learned VertiPrep and in terms of the power of it, right? Let's say you've got someone with perio, right? You've got a lower premolar, and it's root filled, and it's got an MOD, and it really needs cuspal coverage, okay? And really, the restorations are onto dentine, and so really, an onlay is not the best option because you haven't got enough enamel, right? So let's draw that scenario. You got, by the way, my drawing's horrific, okay? Let's just say that's a premolar. This is the root. Okay, so let's say we are, here's the gingival level here, okay? Now, if you did a traditional shoulder, okay, you'd be going like that. You want to make a millimeter or whatever. Let's say you're going to, let's do zirconia, millimeter, and you're going to be going all the way like that. That's going to be a really heavy, long prep, right? So I want to know what dentists are doing in these scenarios, because it can't be anything than Verti for me, and I'll go into that, but I just don't know how you do it. Like there's a tooth with lots of recession. How are people crowning this? Yes, the onlay option's there, but what if you don't have any enamel? So really what the Verti is, and think about this, is what the Verti is that same tooth, okay, crown, root, okay, gingiva, but now we're literally just, nothing's been cut here. There's no shoulder, right? It's just hardly any prep, knife edge, 0.1 millimeters, something like that, right? And then that way you're preserving so much more tooth structure at what we call the peri-cervical region. So that is the best scenario I can think of where, there's no other option than to do a vertical crown. Are you following me so far? Any questions from that?
I'm with you so far. If anyone's got questions, put them in Q&A, put them in the comments, and I'll fire them over.
Perfect. Now, a bit of history. these, well, I mean, yes, we call it Verti prep now, vertical, that kind of stuff, but we've been doing this for like decades, right? So think of those dentists who didn't have any air turbines, and they were using that little foot thing, right? They were like kicking the cycling little thing, and then that was drilling. And so because they didn't have much drilling power, everyone was doing a Verti, right? They couldn't cut shoulders because it took too much time and effort, and it's probably sore for their feet. So back then they were just, doing these tiny little preps, and then probably doing gold or something like that. The issue happened is that the reason why they came back in fashion is because the materials advancement. We can get the zirconia to be strong enough, and also metal ceramic in a way that we can make these really, really thin milled metal or milled zirconia to 0.15. Right? And that's why they become back in fashion again, because the materials now allow us to use these preparations. So first thing to learn about Verti prep is it's just a type of preparation whereby you are cutting very, very minimal amount, okay, instead of doing a shoulder. So you have the whole chamfer shoulder group, and then you have a shoulder less or feather edge. And that's essentially what the Verti prep is. So does that help in terms of figuring out, okay, what it is?
Yeah, I think that's spot on. So you've already mentioned materials there. Materials almost catching up with the fact that the drills are rubbish. But what materials are you looking at here? Because you've got such a thin edge down there. Well, obviously, you're going to have loads of retention because of the vertical nature. There's loads of resistance forms. So cement you're less bothered about or whatever. But materials, zirconia.
Absolutely. So look, some dentists are always going to push the boundaries, and they're doing like lithium disilicate, but I feel uneasy about doing lithium disilicate at 0.15, right? So zirconia for sure, okay? And what they will do is they'll just keep it monolithic in that area, and then if you want to do layering, you can do it higher up. We've got a bit more room for your ceramic. So there's a whole zirconia, and of course metal ceramic. And I've got so many verticals I've done now whereby the metal collar, 1.5 millimeter, the gingiva just grows around it, and it's just hidden under the gum, which is great. So yes, metal ceramic, metal only if you want to do gold, for example, for any reason, and zirconia. Some dentists are doing lithium disilicate, Emax, that's fine, but that's really pushing the boundaries, I think.
Fine. And then you've mentioned about this recession case, and you've sort of just about said there, when teeth with the gum's really healing nicely around it and things like that. So what other cases are you doing for aesthetics, aesthetic zone, replacing metal ceramics, anteriorly?
Sure. Fine. So one thing to remember is that there are some dentists out there who all they'll do is like a Verti prep, and everything will be a Verti prep. Okay, they exist. You also got some dentists. I used to be this dentist whereby everything will be an Emax onlay, right? I went through a phase of just Emax onlaying everything, and that was stupid of me, right? Because you don't have enough enamel in these cases. Sometimes you're on dentine. If you're nowadays, if I'm on more than 10% dentine, no, that's it. That's my threshold. If I'm on more than 10% dentine, so I need at least 90% enamel for me to be feeling comfortable in the predictability of a lithium disilicate onlay. So for me, you have to look at every tooth on its merit. And when a tooth does not have enough enamel, I will go vertical more than often not. I have pretty much stopped doing shoulders unless there's already a shoulder before. So any sort of default crown preparation where I'm going sub-gingival, where I'm cutting a shoulder, or I'm doing like a more conventional prep, I'll be pretty much doing vertical because it preserves so much tooth structure. And also by going into that gingival space, I know you're going to ask me next about, the problems are going down in those dark areas in the gingiva, but you gain so much ferrule. Right? Mm-hmm. So not only do you get, think about upper lateral, right? You got an upper lateral, and you hardly got any tooth structure left, and maybe that's the gingiva here. By doing a vertical, you can really get right under the gum here, and get not only the vertical ferrule, which everyone talks about, but people forget that the ferrule is also horizontal as well. So if you prepped a shoulder, then the strength of that bit of tooth structure here is too thin. Right? So the ferrule needs to be considered in all the dimensions. So not only just vertical, but horizontal. So by drilling less in that area, I got a nice thick amount of peri-cervical dentine. So I'm using it to maximize the ferrule. I'm using it in cases where I can't bond because there's not enough enamel. So my default choice is bond. Where I can't, I'll go vertical because it preserves so much tooth structure. It's an easy prep. It's such an easy prep, right? And we'll talk about the burrs and stuff, right? But it's a much easier prep because, to cut a beautiful shoulder all the way around is very precise. And there are just so many different steps to it, whereas in vertical, there are fewer steps, and it's idiot-proof, and I'm an idiot, so I need that.
Yeah, I mean, as I say, the horizontal ferrule, massively important. Your premolars, lower incisors. Yeah, that's a great example of not having, teeny, because then you're just going to snap it. So absolutely, I get that. One of the questions we had was this versus BOPT, and I'm going to lose it because now there's a third different thing apparently. But so what is BOPT?
So on the board earlier, I had Ignacio Loy's name, and everyone should read his paper. Like, if you just type in BOPT Ignacio Loy on Google, like, his paper will come up, right? And it's free. You can just download it and read it. And essentially, BOPT was like, if you put it in the same umbrella of vertical crowns, right? BOPT is when you're really doing something called gingitage, i.e. when you're doing the preparation, you're really going subgingival, and as you're prepping, you're removing the gingiva, and that causes it to bleed, and that causes it to form a blood clot, and therefore you get this new gingiva maturing, which will then take up its new position. And the crazy thing about vertical is that I've been able to almost like bring the gum down, as in, like, I'm almost like, before and after photo, you actually see the crown, and then you fit the crown, and you feel like, oops, crap, there's some recession that's happened after a crown prep, right? But then you come back, and the gum has crept and grown, okay? Why does it do that? Right, so let's just talk about that. That's really important. Because on the same team of BOPT, we've all had that molar, right? We've seen that molar. The molar's got a cavity, okay? The patient comes in, okay? And guess what's inside that cavity? All that gingiva has grown, okay? So we accept the fact that gingiva has grown in here. We get our rose head or a thermocut and we cut that away. Why can't we accept that the gum, when you give it the right environment, can also grow, in this direction when you create the right environment, right? If you can grow it into caries, if you give it the right environment, you can actually grow it. And BOPT is part of that, because you're doing this gingitage. You're removing the gum, you're resetting it, and then where does it go? It basically tries to find the margin. So the reason it went in that caries because it found a little home, right? It found a little place where it found stability. So in a similar vein, when you're doing a BOPT and you're going subgingival and you're getting that blood clot, okay, the gum will then regenerate. And where does it stop? It stops where you made this prosthetic CEJ. That's the key word there. We create a prosthetic CEJ. So instead of the enamel, that CEJ there, we've created that with our restoration. Because enamel, like, the transition from root dentine, and there's a bit of a bulge, right, where the enamel comes at the CEJ. So imagine that in zirconia now, and that's where the gum settles. So you can control the position of your gingival zenith by doing the BOPT technique. You can also do, but you can also do vertical crowns supragingival. Mm-hmm. Technically, that's not BOPT because BOPT involves removal of gingiva. But the other day, I did a supragingival one because I had plenty of crown height, right? It was one of those recession cases. Like, in that one I showed you earlier, that premolar, why do you want to go subgingival? You don't need to. You've got plenty of resistance form. Just keep it slightly supragingival. It's all fine. The gum might not follow it because you haven't done that gingitage, but you managed to reduce the amount of tooth you're removing.
Mm-hmm. Straight off, we've had the question. I was almost waiting for it when we did the first bit, to be fair.
Biological width, right?
Yeah.
Okay, fine. All right, look, okay, fine. So biological width is a funny thing, right? And the more periodontists I speak to, like, it varies individual to individual, okay? And I would encourage everyone to read the works of John Coyce on normal crest, high crest, low crest, really fascinating stuff. So if you get some chance, like bedtime reading, read the stuff by John Coyce about high crest, low crest, just get an understanding of this, because this is brilliant. But essentially, firstly, we're doing it in cases whereby, let's say you got deep caries, right? The caries invaded the biological width, not me. Right? That's what Pasquale Benucci taught me. It was the caries that went there, and guess what? The bone didn't recede. The gingiva didn't recede because the caries was there. So the caries was there. So now we're creating this environment whereby we get this polished metal, or this polished thin zirconia, right? And with that, you don't seem to have any long-term issues with biological width. We think it's because we created this prosthetic CEJ, so it's not a very plaque retentive area. The gum loves zirconia, for example, and therefore we're not seeing this biological width issue. So the ability for it to be smooth, the ability for it to be thin, and creating a prosthetic CEJ. So everything you learn about biological width, you have to forget when you come to doing vertical crowns or the BOPT technique, where you're really going subgingival. You decide where you want it to be.
Well, it makes sense because the tooth naturally it doesn't lose anything when it's got a CEJ. So if you're recreating it, I guess it comes down to how knife edge, skill of technician and quality of scan, I guess, or imp, and we'll get to that later because obviously we're going to talk about some impressions.
Actually, I just want to mention, Ruben, because I forgot to write his name on the board. I feel so bad now. I was so rushed today. George Cardoso.
So it fits.
George Cardoso taught me so much, and he actually came on the podcast. I haven't released it yet, but we talk all about digital vertipreps, right? Like how can we harness the power of digital, so subgingival scanning for vertipreps, and he taught me so much as well, actually, on that. So I want to mention that as well. So George Cardoso, prosthodontist, he's doing a lot of it.
Clear guy.
Yes, exactly. Yeah. So that's coming up as well, and then he's taught me a lot. Sorry, what was the question again?
No, so we'll cover it. We'll cover it later.
Fine.
So basically, it's going to come down to the margins and making sure that it is, because obviously, if you get it wrong and there's a ledge, that's a different matter. If you're executing it correctly, you're saying it's not invading that width.
Absolutely, but one more thing to it is obviously the biological width is made out of the connective tissue plus the junctional epithelium, right? Mm-hmm. The limit is like you can pretty much go into junctional epithelium. When you're in connective tissue, that's the limit, right? So what if you accidentally go into the connective tissue? Let's talk about that. Let's say you're doing a vertical preparation. You accidentally go into connective tissue. It's bleeding profusely and you're really far down. You're pretty much kissing the bone, right? So if you're using one of those BOPT burrs, which is like what we use for like a endo, right? You got a burr, okay? And then instead of it being diamond everywhere, this portion here is non-cutting, okay? Mm-hmm. So that when that goes in, it's not going to be cutting a margin at all. And then with these burrs, it's almost acts like a thermocut burr. There's no diamond there. It actually just gets rid of the gingiva really nicely as well. So there's a lot of benefits to a BOPT burr. Now, let's say you sink that in, and that is now kissing the bone. Imagine you're on the bone, okay? And you're kissing the bone, and it's following it around. You pretty much invaded the connective tissue there, right? So what the trick there is, you recognize that you've done this, and then your temporary, you give it a millimeter and a half, okay, away from the connective tissue, and it will just heal beautifully. Now, here's the thing: when you're doing these long-term preparations, and if I'm in the connective tissue for some reason, I'm probably not going to go for definitive, especially if I'm in the aesthetic zone. So you give it time with the temporary. You make sure that on the day you remove the temporary, that the tissues look good. And if you respect the tissues, they will respect you. So that's how you do it as well. So yes, I think the junction, I say the biological width isn't an issue, but you have to really not take the piss and go into connective tissue. Junctional epithelium, possibly okay, but don't go in the connective tissue.
Mm-hmm, mm-hmm. So we sort of you said BOPT and Verti is sort of in the same kind of family, similar principles, but not. Then obviously on the other side, we've got the other Instagram indirects, our onlays, and then conventional crowns somewhere in the middle.
We don't see those on Insta anymore. We only see verticals, or we see lithium disilicate onlays. We don't see the conventional crowns anymore.
Don't see the middleman. So then, have you got certain indications that you're not using this for? What are you not using? Because you said you went all into onlays. Have you gone the other way and gone all into verties, and now you're finding your way back? And what are your no-nos for these kind of cases?
Right. You know what? The biggest thing for me is like if you've got enamel all the way around, then bond. I think if you can isolate it, you've got enamel all around. So I think Verti in a way is minimally invasive because of how much tooth structure you get to preserve. But if you're having to remove all the enamel for no reason, just do a vertical, then I don't get it. This is bond, right? Just bonding works. We know that. So for me, it's either it's got lots of enamel, let's bond, or it hasn't got enough enamel all the way around, or I really need to some reason go subgingival for whatever reason. And another case, actually, and this is what Lincoln Harris taught me, okay, and I respect this a lot, is that patient who has got caries in a fashion whereby you start removing the caries and it's like flaking away, and you're almost having to go 360 degrees around the sort of gingival margin because they've just never brushed that area before, and it's all flaking away, it's all soft. That tooth, potentially, you can't do a 360 degrees GIC, right? That tooth actually needs a crown, right? Now, because you're getting rid of all that soft enamel there, then vertical works really well there because you're going to tuck it in the subgingival area. And the beauty of that is when you tuck it in the subgingival area, the way that the vertical crowns seal, the way they seal is that you won't get caries there again. It's subgingival, right? So sometimes there's the gingiva, it compresses and it stops you from getting caries. and which is fascinating. So sometimes, maybe someone with dry mouth, and maybe they've had radiotherapy, and now, although they've got enamel, they've now suddenly come back with root caries on several teeth. I may choose to then actually do a vertical there to tuck everything under the gum on purpose, and let the gum mature around it and create that tight cuff, which is really fascinating, something that dental school would never even think to teach you. But that's what Lincoln Harris taught me, and I agree with that philosophy now. So it's not often that I do that, but it's something to bear in mind. That's another indication.
No, that's a really interesting thought, actually. You open it up. We've taught case selection. We've sort of taught materials. The two other questions that we've had already, main things is about communication with your technician, translating the margins. But we'll get to that in a second. Let's talk imps is impression club. Let's talk imps. Let's talk scans. What's better? What do you use? I know, well, we chatted last time on this and you said 98.2% digital. So is that the same for Verti?
Nowadays it is, because I've really worked on my protocol for digital. And I used to do, like, even though when I had a scanner, like, I knew that, okay, if I'm going to do a Verti, because I want my PVS to go really subgingival and get that detail, I'm going to be electing to use a two-stage impression technique or something, or one-stage light body and heavy body, for example. But now I'm comfortable with my digital side of things. And the key is really good retraction, okay? And nowadays, like, what's one thing that we can do to prevent us going into connective tissue is we can actually place some Teflon tape, really subgingival, as subgingival as we can go, and then the back burr will be contacting the PTFE, and that creates like a barrier. And then you leave that there, and then because you've done that gingitage, it creates that bleeding all the way around, okay? And then you can soak some retraction cord with Viscostat Clear, which is my favorite astringent, okay? It's just phenomenal stuff. It'll get rid of the bleeding, and then you've got a clear path. And what you're scanning basically is the PTFE all the way around. And that's subgingival. And then when the crown comes back, the technician knows exactly, okay, I need to finish at this retraction cord, or I need to finish at this PTFE. Now, if you read Ignacio Loy's paper, where they finish is determined by the laboratory themselves. And they've got like a little window where they can finish. And as long as they finish in that window, the gingival will grow there. So then when you're doing anteriorly, is aesthetically determined. So if you're doing anterior, the lab might determine it aesthetically. If you're doing anywhere else, you can determine it by creating a stop yourself, right? And tell the lab, okay, go all the way to the stop. And they basically will mill it. And here's my protocol for people, Precision Dental Studio, right? What they do is they will mill the crown, okay? Because the thinnest you can mill is 0.15. This is what they taught me, 0.15, right? Let's say this is the prep, okay? That's the prep, very vertical prep. So 0.15 over here, okay, is how they mill it to. And then they're going to make the crown. So I know that looks like a really big 0.15, but let's go with, they want to make it. If that's 0.15, and then what they do, Rupert, is they hand finish it to infinity. Mm-hmm. But then the main thing is that from here to here, it's 0.3 millimeters. Okay, so it's actually then coming out to, it's like a CEJ. It's coming out to 0.3 millimeters, and then that's how it gets its strength. So when we're worried about being too thin at the bottom, two things. One is, yes, it's very, very thin at the bottom, but then it tapers out. It has that sort of 45-degree taper to 0.3. It's not like knife edge all the way along. It's actually 0.3 and then all the way up. Okay, and the gingiva will just settle over there. So there's that. And then also what Pasquale Benucci taught me is that we're always like scared about going too thin, right? Like 0.15 at the margins or polished to infinity at the margins is way too thin. But what Pasquale taught me was that if you got enough occlusal clearance, if you got enough thickness of material occlusally, then that's what's going to absorb the load and not your margins.
Mm-hmm. And then, yeah, so what are you using for this? I know you've got both scanners, haven't you?
Yeah, so whatever's available.
You got the third one as well. Have you tried that out yet?
I tried the Medit just yesterday, actually. I tried the Medit, yeah. Niall came round. We tried the Medit. I was very impressed at the scanning speed of that, the face scan. That seemed pretty cool. And that is what George Cardoso uses. He uses the Medit, and he thinks it's like the best value scanner you can get at the moment. And associates should buy it, that kind of stuff. He's quite passionate about it. So Medit, all these scanners can do it. I've done it on Itero. I haven't done it on Medit, but George Cardoso does a Medit all the time. I've done it on 3Shape. It's fine. As long as you can see all the way around that PTFE tape, and you can get the light to go there. And sometimes you have to go back and just remove a little bit of gingiva. For example, let's get rid of this. Right, so let's say this is the premolar example. We have no margin here. It's completely like marginless. This is a typical vertical crown, for example. Here is the gum. And then in this gum over here, instead of being like this, okay, it's like after you put the cord in, it sort of collapses inwards, right? So it can't get to this part. Okay, so can you see it's curving inwards? Mm-hmm. So what you then do is actually just do a bit of gingivectomy here, so that the light of the scanner can actually get to the bottom of that PTFE tape. So these little tricks that, you know, we pick up as you go along.
Right. And the next bit I want to, you touched on it briefly earlier about temporization, but how are you are you doing, you know, your standard pre-op putty, stent? Are you leaving that PTFE in so that you can get the temporary down there to allow these gums to come back in? And then one of the questions we had in the chat then was, how long after that are you taking to deliver? You said you might be reviewing and seeing how the gums are doing. Yeah. Is it ever a case where actually you might temporize 2 weeks, come back, scan it at that point? You know, how much is it about emergence, you know, almost turning into implants now, an emergence profile and that kind of stuff? You know, are you ever doing that kind of protocol? Let's cover temps first and then sort of delivery sort of.
Sure. Can I answer the question by Dr. Yazid Al-Johani first, right? Which is how long does it take to deliver the final vertical restoration before the whole gingiva matures? Okay, so certain teeth, like if you're going to BOPT technique, which is like you're going all the way subgingival, you're creating that fresh blood clot, then I want to get think of it as like crown lengthening or periosurgery in a way. Then you want to put your temps on and wait, let it heal beautifully. So I'll see it again, maybe, you know, Jason Smithson teaches 40 days because that's how long it takes epithelium to heal, famous. So that's what Jason Smithson teaches, 40 days. So some number of weeks, whereas some clinicians will wait much longer. I'm happy to keep some temporaries on for a year. Like when I'm unsure of a prognosis of a tooth, I sometimes just prep it as a Verti, put a temp on that day. And if it's going to last with a temporary for a year, then I know my definitive will last a year. And nothing's coming out. That's not, you know, when you use a Verti temporary with something like Duralon or zinc polycarboxylate cement, it's going to stay on because you've got such nice sort of long parallelish walls. It stays on very well. So the answer to that question, to be direct, is if you're doing an aesthetic case or you're going for that BOPT, you're really creating that gingitage, then take longer. If you're doing a non-aesthetic area and you haven't really gone that subgingival, it's much more predictable. I will very often just scan and then fit in 2 weeks. And yes, on the first day, it might be like slightly too subgingival, so the gingiva blanches, or it may be slightly shy. But a few weeks later, it settles because that's the beauty. You have that zone, right? You create this nice polished area. You have seen some of my preps. It creates a nice polished area. And then the gingiva can go here. It can stop where it wants. And it's almost dictated by that restoration, which becomes a prosthetic CEJ.
Mm-hmm. Mm-hmm. So, and in terms of the temporization, then, if you are doing it for a year, what materials are you using for that? Is it a Lux temp job? Have you tried Luxa Crown? That's the new one. Luxa Crown is pretty cool.
I mean, you can do any like those director crowns, right? That you like adjust and you reline it. You can do a lab made shell temp and reline it. Okay. Very often I'm a cheapskate, you know, take a putty beforehand and go for it. But little hack. If you're going to try this at home, little hack. Thank you, Dr. Yazid Jalani. Right. So little hack. If you've got a let's say a upper incisor root, okay, gingiva. Okay, and we're prepping this tooth. I know that my zirconia is going to be very, very thin in the future, and that's going to be strong enough. But the bisicral, like 0.15, 0.2 millimeter bisicral, is very, very thin. So the hack is you dry the sulcus, you get some flowable composite, and you just beef it up. You put it 360 degrees, you beef it up, right? And then you take the putty index. Then at the end, when you come to making your temporary, it will have a thicker bit of sort of bisacryl to play with. And then you can taper it and polish it and tuck it into the gums, basically. The other way to do this is not to do this, but when it comes to taking the impression, maybe you guys see this on Instagram or on Ignacio Loy's paper, is that, in fact, I've got it right here. Let me show you. So in this case, can you see that all right?
Yeah.
Okay, so in this case, what Ignacio Loy's done is that he didn't put that flowable composite all around the tooth. He let his very thin temporary go there. He highlighted it with a pencil, and then all this area you fill in with flowable composite. So you're beefing it up afterwards, and then you're going to bevel it, like so. And then what you create is this. And you can see here the angle that it makes, and that's a prosthetic CEJ right there, right? You know that the gum's going to love this smooth area and just grow there. So everyone should download that journal by Ignacio Loy. Really, really good.
Oh, perfect. Send me the link for it. So I'll put it in the description. Perfect. I mean, that the first sort of tip that you said, adding the flowable, then doing the that's sort of a more sort of obvious one, because you'll do that all the time for a lower right 6 MOD, buckle cusp off, blob a composite, bite into it, cure it, polish it later. But yeah, I don't know how long that's taken. It's a beautiful temp, that. And then potentially you're saying leaving it on for months for it to mature. Is this more the BOPT bit, or more the BOPT than the Verti?
Yeah, I agree with you. I think
you're
really going sub-gingival, and you're like, think of it like, if you want to influence the gingival margins, if you want to influence them, then you're more in the BOPT, biologically orientated. You're creating a bleed, you're creating a blood clot, you're playing around with the margin. If you're just maximizing a ferrule and it's a lower premolar, or they've got a low lip line and it really doesn't matter, you don't have to wait months. You just crack on, make it temporary, and you can make your temporary like finish like really shy of the gingival area, and the gum will just grow. It will follow, right? Because it's got this lovely smooth prep. Gosh, that's terrible. This is a pointy. So it's lovely little smooth prep, and the gingiva will just follow, right? And then whenever you put your crown, it will just adapt. So the answer is, if you're working in a non-aesthetic area, you can get away with a lot. If you're working in aesthetic and you're trying to manipulate the gingiva, then you're doing more of the BOPT. That's a good way to think of it.
Yeah, more for your aesthetic cases. You've maybe had a dodgy metal ceramic on it already, and recession, and trying to blend it in and grow it back. Day of delivery then, obviously doing all this normal stuff, you're taking that out, cleaning it all up. What are you looking at in terms of the gingiva, trying it in? Are you doing a bit of blanching and then letting that settle before trying to cement it in? What's the process for day of fit?
Great question. So some preps, because you left the temporary on purpose or by accident, whatever, you left the temporary not very subgingival, and with the shape of that new temporary prosthetic CJ, the gingiva grew, and now when you come to fit the crown, there's blanching of the gingiva. Okay, therefore in that case, bite on a cotton roll, leave them 5 minutes, go have a coffee. Okay, it will just seat and sink back in. In other cases, you're going to put it on and you'll find that, oops, I'm like half a millimeter, even to a millimeter shy of the gingiva. But you still got that very thin knife edge crown, the prosthetic CJ. And guess what? When you cement it, the gum will grow. Just like it grew in that little MO cavity, the gum grew, it will grow. Okay? So especially if you've done the gingival charge. If you haven't done the gingival charge, it might not. I.e., you've kept it super gingival. Because if you keep it super gingival, then you've created an undercut, basically. I don't know if I need to show that visually. I don't know if that makes sense or not, but let's say we're keeping a tooth super gingival for whatever reason, because you just don't need to. Let's say, here we are. Here's an example. Okay, so here we are. Here's the gingiva. Okay, and on purpose, we're keeping it super gingival. Okay, but as the impression material goes, or the scanner, it can go here and it can go here, i.e., an undercut. So the technician knows, okay, I'm finishing here at the undercut. and therefore the gingiva is not going to grow because it's got the undercut in the way. So once you get rid of the undercuts, i.e. like this, then the gingiva will follow. So like I said, so some people say that, oh, you can't do a BOPT super gingival. Yeah, you can't. Hence why it's a vertical when you do it that way as well. Verticals can be subgingival, it can be super gingival, and it doesn't always need to be. So people think that, oh, you need to create lots of bleeding when you're doing a verti prep. Not always the case. So on the day of fit, yes, either it'll blanch or it'll be a bit shy. Don't worry, it'll settle. And then often you can also put PTFE tape then as well, okay? Because when you cement it, especially if you're a little bit subgingival, you don't want too much of the cement there, right? And using conventional luting cement, RMGIC you can use zinc phosphate for all you care. But then to have that PTFE tape in and you remove it, then it just all that excess comes away, which is nice. It just comes up quite nicely. And obviously you don't want to be using resin, especially if you're doing a more conventional vertiprep subgingival. So I'm either going to use a GIC like Fuji Plus or zinc phosphate, that kind of stuff.
We just had a question pop up, the Dental Passion. In cases of anteriors, when the gingival zenith is at different levels, what procedure do you follow for temporization? So are you doing anything differently if the gingiva is different? If you're trying to mature one area and not the other, or is there any sort of thinking in that way?
Okay, great question. So firstly, diagnosis, right? Like if you've got someone with like one central gingival zenith is here, okay, and the other one's here, right? Then you need to figure out what's going on there, right? Because maybe as that tooth has worn, it slowly started to erupt a little bit, and then you might notice, okay, this incisor is 9 millimeters, and this incisor is 7 millimeters, and that's because as it's worn, it's come down a bit. In that case, you're trying to move a gingival zenith up 2 millimeters, okay? Then you're getting that connective tissue zone, so that's not a vertical case. That is an ortho intrusion case or a surgical crown lengthening, but ideally an ortho intrusion case, and then build up the edge. And then the orthodontics we can use to actually intrude the tooth and get the gingival zenith right. Now, if you've got plenty of flappy gingival margin and it's about a millimeter and a half, and you maybe done some bone sanding, which you numb them up, okay? You get a perio probe, you get all the way up, you just figure out where the bone is, okay? If you've got a fair bit of distance, fair bit of play, then you can use this technique whereby you can make the gingiva match the adjacent tooth. And essentially, you're doing it the BOPT way. You're going subgingival, okay? You're pretty much kissing the bone with that burr, right? The diamondless burr. You're kissing the bone. You're creating that fresh blood clot. And then with your temporary, you are deciding where you want to finish. So you create the prosthetic CEJ with your temporary, and you say, okay, I want my gingiva to finish here, and that's where you finish your temporary, or at least that's where you have the undercut of your temporary, right? It's like a beefy temporary that you make, and then you decide, okay, I'm going to make it here. I'm going to bevel it in, and that's where I want my gingiva to go. And then you give it some time. You give the whole 40 days for the gingiva to mature, and that's the best shot you have of getting those gingival zeniths even.
So potentially it's another indication for doing it. If you're wanting to do when you've got a little bit of gingiva indifference, and you're trying to just in that aesthetic zone, obviously you're not too bothered about what the lower 7 looks like, but that's maybe another indication to do it. But so you're not doing a conventional crowns unless you're replacing one anyway.
Absolutely. You're saying that, and I'm looking at Ignacio Loy's paper to show you that exact example. So look, that one's a little bit higher.
Perfect. Yeah.
Right. And then he's actually made it lower. Look, by doing the new crown, he's actually brought the gum down. Can you see?
Mm-hmm, mm-hmm.
So it's not just when you're making it higher, you can actually make it lower. So the way you do that is you do the BOPT, you make it bleed, okay? And then you make it temporary, very much shy of the gingiva. And it will grow to the prosthetic CEJ.
So you've almost got to stimulate it by doing that sort of BOPT prep.
Yeah, that's it.
And then it's been set there by the current position of the crown. You then give it a nice smooth area and guide it. It's a lot of sculpting this temporary and sort of reverse engineering in your head, isn't it? And working out. So you're giving it a definitive sort of angle change to sort of tell it, oh, this is where I need to stop. That's what you're sort of training the gingiva to do.
That's it. And it's all done with the temporary, and it's all done with being decisive beforehand. But it depends on the case. So if you got that sort of aesthetic case, then yes, you're going to be doing that. I think Hard's got a question, hasn't he?
Yeah, so that's more on the instructions and communication with the lab. about the location of the margin. I'm assuming you're using the same technician who already knows about this kind of thing and not thinking, God, this guy never gives me a shoulder. Is it sort of thing where you've spoken to your technician about it, or you've searched down a certain person? Is photos useful above just a scan? What sort of things are help?
So firstly, if you're going to send anything to your technician, obviously tell them what's in your mind first, okay? And I, every time I've spoken to a technician, I've introduced the vertical concept. I always send them Ignacio Loy's paper, because it covers the lab stages as well in that paper, which is awesome. And then some things that I've been taught by Pasquale Venuti and Alina Rizanova, I've just sort of plagiarized them, and I've sort of trained my lab, and I said, okay, here's how you need to do it. And then sometimes my own failures, I've had one case of chipping, and I realized what I've done wrong in that case, i.e. I didn't get enough space in that one area, and I didn't get rid of all the undercut, which we can talk about. It gets a little bit complex without any visuals, but essentially you'll make some failures, and then you can better inform the lab at what you're trying to achieve. And essentially what I would encourage is you create the lab a very specific protocol and draw them diagrams. Like, you draw them diagrams. You want to then be very prescriptive. You want to tell them that, okay, your first is going to be it's going to be hand finished to infinity, to nothing. Then you want 0.3 millimeters. Then you want it to be like a more conventional crown preparation. You're going to use these materials. You're not going to use these ones. Sorry, you're going to see my terrible drawing again. So essentially, you've got to have that, and I would label it for the lab. I would say, okay, that's going to be 0.3. That's going to be 45 degrees. And so I send that to them. You tell them the spacer protocol, right? So conventional crowns, okay, they have, no spacer at the margin, right? Because you want it to seat beautifully, right? Whereas they have spacer all around. Whereas in this case, you don't have as much spacer occlusally, because you wanted to seat there, because that's your reference, right? Mm-hmm. And you do have spacer by the gingival margin there, actually. So it's a different way of thinking. So you've got to learn yourself and then train your lab. Funny thing is, I got so busy. I was speaking to Jason Smithson about writing a paper together to help train everyone with labs and stuff. And I kind of made it. I made the PDF and I sent it to the lab. And I'm begging to just get it perfected so I can share it with everyone. But coming soon, I think. But essentially, get a protocol, have a chat with your lab, and make it very visual for them, and send them Ignacio Loy's paper. And to be more direct for Haj, for a lot of these cases, which are just like you're trying to maximize the ferrule, like I was saying earlier, I don't know if you joined the Haj before, is that I've got PTFE in the sulcus, and that's my stop. And the lab know that the end of the scan, or what they see in the scan, is the end, because I put some protraction cord of PTFE, so I've prevented this biological width invasion. And so they'll just go all the way to the end, and they'll hand finish it there, and then create that 0.3, and they'll create that taper from there. So that's the easy way.
It's almost potentially easier for the lab, because you just say, go as far as you can, make it super skinny, but go as far as you can. Like,
go as far as you can see, find the undercut, and then start the protocol of 0.3 or 0.15, and hand finish it, and then have that 0.3 margin with the angle, and then they just do it on the computer really quickly now. They probably have my setting saved, and they can probably, just go for it.
They got the template ready to go. To be fair, I did a prep, almost a hybrid. It was replacing a crown on a lower 7. Our endodontist did an absolute wonder endo on it. It was deep caries mesily. And with the angle and everything that it was at, I just couldn't get into a shoulder in at this mesial point. And I got the exact same burr completely by, it was the longest, thinnest one that I had. I didn't even clock really that it didn't have a non-cone tip. And the mesial is essentially a Verti.
And you can do that.
Because it was polished out. And the rest of it was just refining the margin that was already there. And I said that to the lab. I said, just get it as far as you can, make it sort of super skinny. And, well, I'll let you know when I fit it next week. But it looks good. And I didn't get an angry text back from the lab saying what's going on. So, it's definitely something to look into more.
Which material did you use?
Zirconia.
Okay, good. So, monolithic in that area. They make it very thin. You got to have enough occlusally, enough occlusal clearance, thickness in that area. And you can sometimes, you're forced in that situation. Like, imagine you're treating an upper molar distally, and you have that trifurcation, right? And you don't want to be, like, if you're on root dentin there, you don't want to be cutting a chamfer in the shoulder and a trifurcation. If you just make it smooth and subgingival and create that 0.1 millimeter feather edge in that area, that's what you want.
With the metal ceramics, you said metal ceramic for it. Is that not a metal cuff?
Yeah, absolutely.
Yeah.
Metal
so
cuff,
that,
360 degrees.
yeah, you got. I'll say you got the metal super thin. So then, obviously, more anterior aesthetic stuff. You're not going to be going for that because that's
Correct. I'm going to go zirconia. I mean, soft tissue loves zirconia, right? So I'm going to go zirconia. To be fair, even if I want to go metal ceramic, I'm quite confident that I can hide that metal on subgingival. But why take that risk, right? Just use subgingival. Just use zirconia.
Yeah. That makes the most sense. And you're not going to want to go Emax anyway because you're going to want to bond the Emax. So zirconia,
exactly. You don't bond the Emax. I think like the strength of the restoration decreases by half or something like that. Like, don't quote me on that, but it's quite significant. Bonding versus not bonding, you have, if you're using Emax, you're really playing with something that's much weaker, that's cemented.
Perfect, man. I mean, that's covered it really nicely. I'm going to start doing loads of Verti preps now.
Well, I was just going to say, because one thing I was afraid of was like in this, I don't know, half an hour, 35 minutes that we had, like, it's impossible, and especially because I didn't have time to prepare because of all these issues. I didn't have time to show any of my cases and whatnot and go through it. Sometimes I post them on my story and stuff. I think everyone who's serious about doing it should do a course, okay? So let me tell you some courses out there, okay? So there's Jason Smithson's course, okay? He does a live one, and he has like an online version as well that you can like learn the theory in a much better way than our live, but it'll just open everyone's mind. There's burning question, what's a verti prep? Hopefully we've covered that today. So there's Jason Smithson online and in person. There's the Italian group, Tomorrow Tooth, really great Facebook group. They've got the online course there as well. And then I've been speaking to George Cardoso. We want to take a group of the Protrusive in 2022 to Portugal to learn Verti, but really want to go to his dad's seafood shop, to be honest with you. Any other burrs, Nina Wilson. You can use, technically you can use any burr, right? You can use any burr to do it, but
it's just got to be narrow. You don't want anything too fat.
In the Ignacio Loy BOPT way, they use these flame shaped burrs. Okay, and it's very technique sensitive. You want to almost like, that's the CJ there. You're almost taking that burr and you're angling it like this, right? You're angling it like this, and then you're straightening it up. It's quite technique sensitive, and you can cause like scratches on the root surface when you're angling it. The idiot-proof one is the bat burr, right? So that's diamondless, and the beauty of that is that you stick that subgingival. Okay, now you put the tip up against the root. It can't go into the root, and you just follow around. It's idiot-proof. Just let the diamondless bit follow it all the way around, and then higher up it'll just prep, and you get this lovely classic shape of vertical.
Nina's testing you on your knowledge of the dental directory. Is it the 557 burr?
I will have to check. I've got the bat burr code somewhere. Yes, Haj is right. Sweden and Martina have got a great set of burrs. If you're going to go for the BOPT way, if you're going to go the Tomorrow Tooth way, which I'm a big fan of that. I know Jason Smithson isn't 100% big, massive fan of that, but that's the beauty, right? Like I always say nowadays, inspired by Alan Matthews, one of my friends, is listen to everyone and do what feels right to you. Okay, mm-hmm. So I listen to everyone. Like I listen to all these schools of thought. Like I consumed so much knowledge before I did my first vertical preparation, and I now have fine-tuned my own philosophy, and I encourage everyone to do that. So yeah, Sweden and Martina have burrs, the flame-shaped burrs, but also the bat burrs as well. It's all out there.
And we're getting a protrusive episode on it, right?
We are. It'll be digital Verti Preps, and I promise you, George Cardoso will do so much more justice than what I did for Verti Preps. I hope I helped a little bit, but honestly, today I've had a crazy day. Like my wife had to have a COVID test yesterday. I had to rearrange my patients. I was almost not going to be able to make it today, so I'm sorry, everyone, but I'm hoping you guys got some flavor of what it is.
Nah, but spot on. I've got one last question, which is the one I've been throwing at everyone recently. What's the one thing that you know now or you do now that you wish you were doing? How long you graduated? 7 years? 8
years now.
Yeah.
Right.
FD,
what's the one
first
thing?
year in practice. It doesn't have to be about Vertis or anything.
Oh yeah.
Just a top tip for a young dentist.
I feel I sound like a broken record because I say this all the time. I care a lot. Like you have to care. Like it's called healthcare for a reason, but at the same time, don't care. Right? So let me expand on that, right? Care that you want to do the best job you can. Care for that individual on an emotional level, right? Like make that emotional connection. Really create that rapport with the patient. but don't care so much about that patient's tooth that you take your problem home with you. Don't make your patient's problem your problem. So care, like really care. But there's a point where, you know what, I'm like, before, I used to get very nervous about telling patients about risks. Like, I sometimes say to a patient, like, you know what, we're going to do a crown, but there's like and I used to quote like the worst figures, like, you know, 1 in every 6 crowns going to, I do so many crowns, trust me, 1 in 6, I'm not doing like endos 1 in 6, like maybe 1 in 20 or something like that, right? So you say to the patient, oh, there's a 1 in 5 chance you might need a root canal treatment. You're almost nervous, right? You're choking as you're telling this patient, like, okay, you might need this, or you might need a root canal after this filling. And now I'm so much more chilled about it. Like, just calm down, everyone, right? It's just a tooth. Tell the patient, you got a hole.
Yeah.
Your problem. You might need a root canal. Do you want it or not? Not like that, but 100%. Really,
yeah,
that's the main thing.
I'm with you on that.
It's one milk of France,
something in the last year that I've been on. One milk France. And the root canal and the crown is the classic one, or this year, this 9 months or whatever it's been, the COVID crunches, clenches, whatever they are, you know, and everyone's cracking teeth, and you know, you do a really nice onlay prep, get those cracks gone, and then 8 weeks later they come back and, you know, irreversible, and you're going, oh, it's not my fault. It's not my fault they cracked the tooth. I did, you know, the nicest IBS, blah, blah, blah. Listen to the last episode on onlays. It was fantastic. I really enjoyed that one. But yeah, exactly that. You go, oh God, and they still need the endo, and you go, it's not your problem. It's not.
Don't feel bad about the patient's problems, right? They cause it themselves. Like, obviously, like, hey, guess what? Like, really crazy. Okay, I have to share this with someone. Okay, I spoke to a patient today whom I referred to Torquay Hospital 5 months ago because they had a weird lesion, and I was like, and he lives in Torquay. I was like, okay, just get it checked out. In the last 3 weeks, he's had major surgery for oral cancer. So this is my 8 years as my first mouth cancer diagnosed. So everyone, keep your antennas open, keep looking, keep referring. There's no such thing as and it was like, whoa, I was really sad for the patient, but he got the all clear today. So that's amazing. So yeah, care enough to do a thorough exam and look, but don't care about the problems that they've created, and don't make them your problem. Don't feel bad about giving them risks.
100%. I'm with you on that one. Can you send me over that paper so I can put it in the description?
Ignacio Loy, absolutely. I'll send that paper. That's like the classic paper everyone should read before even thinking about doing a Verti.
Mm-hmm. Perfect, man. Well, I don't think there's any other questions. We've all got to go and watch France win.
I know, right? This is going to be exciting. Okay. Rupert, thanks so much. Keep up the amazing work you're doing with the Impression Club, man. Honestly, what you're building here is really cool. Like, someone today on our Telegram group was asking about how do I learn more about dentures? I said, okay, 3 things, okay? Join Finlay Sutton's newsletter, follow Rupert on Instagram, and follow Michael Gregory. I said, if you do these 3 things, you'll be amazing at dentures.
Yeah, Mike was on at some point, but I think he doesn't do AGPs anymore, so he probably zoned out at some point. But yeah, cheers, dude, and I'll catch you soon. We'll get
catch you soon, buddy.
Practice soon. Cheers, buddy.
See you, mate. Take care. Bye.
Bye.